to this issue should have been held much earlier to address the concerns of the haemophilia community. 2. The procrastination in achieving national self-sufficiency to avoid the use of high-risk blood products from overseas had disastrous consequences. Had self-sufficiency been achieved earlier, the scale of the catastrophe would have been significantly reduced. If in the future concern arises about the safety of blood products, this lesson must be remembered. 3. The doctor-patient relationship during the evolution of this tragedy sometimes had unfortunate consequences. The medical profession appears to have made good progress in this area. The importance of patient involvement when making difficult clinical decisions is now appreciated and should not be forgotten. And 4, commercial priorities should never again override the interests of public health. After the summary of our conclusion, our recommendations are as follows. 1. A committee should be established by statute to advise government on the management of haemophilia in the United Kingdom. It should have overarching responsibility for 1. The selection, procurement and delivery of the best therapies currently available and recommended by NICE. 2. Readily available access to any necessary treatment relating to the condition itself or any condition arising from consequent therapy. 3. All provisions necessary to address the financial and other needs of haemophilia patients. B, and we've set this out in the report, we emphasize the importance of patient representation. We've made recommendations about the composition of the committee in the report. But patient representation through nomination by the Haemophilia Society and other bodies working to support the haemophilia community. C, there should be a statutory requirement to consult the committee prior to the introduction of legislation or substantial changes in policy. And D, where the committee deems it necessary, regional subcommittees should be established to exercise prescribed functions falling to the principal committee. 2. Patients with haemophilia who've received blood or blood products and their partners should be tested for any condition identified by the committee described above. 3. Every blood donor should be similarly tested following the donation. We understand that at present, donations are tested for syphilis, hepatitis B, HIV, hepatitis C, and HDLV. This list must be kept under review. 4. Those who've been infected should be issued with cards entitling the holder to benefits not freely available under the NHS, including free of charge prescription drugs, general practitioner visits, counselling, physiotherapy, home nursing, and support services. The card should facilitate access to an NHS hospital bed and specialist services. 5. We consider it vital that the government should secure the future of the United Kingdom Haemophilia Society by adequate funding. This should be seen as a matter of urgency. 6. Direct financial relief should be provided for those infected and for carers who've been prevented from working. We propose that the scheme should have the following characteristics. A. It should be paid through the Department of Work and Pensions in the same way as existing statutory benefits, so that beneficiaries should receive their entitlements from the government and not through intermediate sources, such as the Macfarlane or Irene Trusts or the Skipton Fund, and is not in any way a criticism of those trusts or funds, but the government would thus have direct responsibility to the individual beneficiary for providing the necessary resources. B. Entitlements should be payable